The American Headache Society meeting in Denver was replete with very important studies, I think, that have implications for neurologists both in the U.S. and internationally. And I'd like to start with a study that Dr. Tim Smith of St. Louis presented. It was an investigator-initiated trial, and he studied the effects of the anti-CGRP ligand monoclonal antibody Fremanezumab in patients with migraine. And what he was interested in was whether the idea that patients have to have a reduction in mean monthly migraine days is necessary for an evaluation of clinical benefit. Let me give a little background on this. In the EU, the requirements in many countries is that at a certain time points after the initiation of anti-CGRP therapies, patients have to have a fixed percentage of reduction of monthly migraine days. For example, in Switzerland, at 3 months, there has to be a reduction in monthly migraine days not specified, but by 6 months, when treated with one of the anti-CGRP monoclonal antibodies, there has to be at least a 50% reduction in mean monthly migraine days. And this is true for many countries that are actually in the EU, and these have been significant problems. It's true in Italy, it's true in other countries. And if the patient does not have a reduction in mean monthly migraine days at this specified amount, they have to have their medications discontinued. What Dr. Smith did was to give the Fremanezumab, establish the baseline of mean monthly migraine days in patients, and then look at 3 months at the percentage of patients who had at least a 50% reduction in mean monthly migraine days, and compare those to patients that were non-responders that did not have that reduction, and measure a variety of very important outcomes having to do with quality of life and function. These included the Migraine Interictal Burden Scale, a sleep disturbance evaluation, a general self-efficacy scale, the patient-reported outcomes measure, work productivity through a scale called the WPAI, and a brief measure of worrying severity. And what he found was that regardless of whether the patient had a 50% reduction in mean monthly migraine days or not, there was a dramatic reduction of interictal burden with improved quality of life, decreased fatigue, decreased pain interference, decreased pain intensity, decreased sleep disturbance, and increased work productivity in the patients who were placed on the Fremanezumab. What this tells you is it kind of confirms what neurologists have seen for years with therapies such as onabotulinum toxin A, where a patient will say, well, I have not had any reduction in my migraine frequency, but I've had a dramatic reduction in the severity and an increase in my ability to function and go back to work. I would submit that the artificial setting of a reduction of mean monthly migraine days is not adequate in evaluating the effectiveness of anti-migraine preventive treatment, and that Dr. Smith's study should be used as a bludgeon to talk to regulatory authorities and change the way they evaluate the effectiveness of these drugs to include patient-reported outcomes and other measures of function.